Thank you. No, no worries.
Thank you, madam, for your elegant presentation. I'm a neurologist. I was interested in regarding, you've done lots of work on Parkinson's disease. Obviously, you presented there. Parkinsonism and falls you had mentioned. We know that the pedunculopontine nucleus is probably involved in the falls in Parkinsonism. But we have a Parkinson's wherein gait instability is the predominant form as well.
Yeah.
And you also listed dizziness as one of the causes Parkinson's disease, which we also do see. My question is, have you had occasions to, in your Parkinson patients, to look at the vestibular system, evaluate the vestibular system, and did you find anything abnormal in the vestibular system?
No, thank you for that. As I say, I think I would really only look at the vestibular system if a patient was complaining of vertigo. And on the whole, Parkinson's patients are really, as you've said, complain more about gait instability, unsteadiness, poor balance. And it can be a very difficult symptom to treat in Parkinson's disease, because I don't know what your experience is, but mine is it doesn't respond to the L-DOPA preparations in the same way as bradykinesia or rigidity would. And once again, I find increasingly physiotherapy the best intervention, and particularly in patients with freezing, which is a very disabling problem, using the cueing techniques where physio, perhaps we should get one of the physios if they're still here. Hands up, the physios that are still here. Split, oh, great stuff. Do you use cueing techniques for patients with Parkinson's disease? That's something you do, yeah. Where they give them like either visual cues, like tape on the floor, or even auditory cues. They give them little MP3 players and get their patient's favourite marching song to give them a beat to walk to, and that often helps them through their freezing. But in terms of looking for vestibular problems in Parkinson's disease, I would really only do that if they complained of vertigo.
You're not formally evaluated them, like doing vestibular function tests, either
vestibular
myogenic potential or caloric test in these people in Parkinson's. You've not formally evaluated them.
I'm not
yeah. Do you have any information on that?
I haven't looked at vestibular function, if you like, de novo in people with Parkinson's disease with no vertigo. No, I haven't.
I have a comment and a question. The comment is that before we do Hall-Pike or Epley's maneuver, one should ensure that the patient is not suffering from conditions like rheumatoid arthritis or ankylosing spondylitis, and the neck is supple or soft enough to do these maneuvers. Otherwise, it can lead to medical emergencies.
I think that's certainly true in patients with rheumatoid arthritis, where they may have an atlantoaxial instability.
Yes.
But that's relatively unusual in people with degenerative neck disease. I mean, let's face it, in old age, degenerative neck disease radiologically is almost universal. Not everyone will have symptoms, but I don't let it inhibit me too far. I certainly wouldn't ever do a Hall-Pike test in someone with rheumatoid arthritis. I absolutely agree.
The question that I had was that irrespective of the cause of vertigo or syncope, do you also advise them adaptation exercises? Adaptation exercises for vertigo.
Yeah, I think increasingly there's evidence to support that. I would absolutely agree, and again, habituating people to their symptoms, and obviously vestibular rehabilitation is now an entity in its own right, and can indeed be very helpful. I mean, I think probably mostly, I mean, in my head, I think it's most useful in people with a small vessel brainstem disease, to be honest, rather than people with benign positional vertigo. I think it would be criminal to send someone with benign positional vertigo for physiotherapy. Just do the Epley maneuver. They will be cured. There is no need for physiotherapy there.
The third comment was that though this talk was focused to elderly, but both for acute vertigo as well as benign positional vertigo, migraine is one of the etiologies which is commoner in the younger age group, may not be at the older age group, but migraine as a cause of even vertigo, and migraine equivalents where headache is not a very prominent symptom. It is the vertigo alone that could be the manifestation, both in an acute setting as well as positional vertigo. Any comments on that? I'm
sorry, I didn't quite catch was it
migraine equivalents?
Oh, migraine. Sorry, yeah. I must admit, I haven't come across that, but I guess it must exist. I'm sure you're right. For the acute
as well as positional vertigo, and there are many patients who have chronic migraineurs, and they finally land up with migraine equivalents where headache is not a very prominent symptom. It is the vertigo which becomes the prominent symptom.
Well, that's very interesting. I haven't come across that. Thank you.
Excuse me. You talked about all kinds of what to do at the time of losing balance or dizziness, all sorts of things, and what should be done. Suppose a person is left alone at home, maybe a male or female, an old person. What he can do at the time of dizziness and losing balance? Is there any sort of knowledge base to be done, given to them? And do you work on that? People left at home, nobody is there to take care. What do we do that? Where do we go for help?
Well, as I say, within a care of the elderly service in the UK, what we commonly do is refer our patients to a day hospital where they would have a multidisciplinary assessment with a physiotherapist who would teach them exercises to do to improve their balance and strength, and provide them with an appropriate walking aid if that were relevant. They would also be assessed by an occupational therapist who would look at their day-to-day activities and would potentially assess their home environment and look at whether there's any, for instance, rails in their bathroom that would be helpful.
That's right.
Things like a perching stool in their kitchen so they're not having to stand for prolonged periods. And also, at worst, if you're really struggling to prevent a patient's falls, what you can do is actually now provide them with what we call telecare or falls alarms.
Yeah, that's right. That's right.
You know, these can particularly pick up if a patient falls out of bed. Also, obviously, just a straightforward alarm that the patient can set off if they land on the floor and can't get up to alert help either from their family or the local social services. So you find ways around.
So they learn the basic steps what to do in case such
Yes,
happens.
yeah.
Thank you very much.
Ma'am, I just got one question. Here, ma'am. Is this regarding the...
Announce your name and from where you come, please.
Okay. My name is Manoj. I'm a physical therapist. This is just regarding the Ellipse maneuver you were just telling me. You just do it once and the patient becomes all right.
The Epley maneuver.
Yeah,
yes.
maneuver.
Yeah.
You just do it once and...
almost always. Well, I mean, what I say to them is I give them my phone number, and I now don't give them a routine appointment because most people were coming back and saying, I'm fine, and it was a terrible waste of time. So now I give them my phone number and say to them, if you're not feeling better in a fortnight, phone me up, I'll give you a quick appointment and I'll redo it. And the second time usually will be effective. Occasionally people will have further symptoms months or years hence. There'll be a recurrence, but they will respond to the Epley manoeuvre again. But it's a nice thing to do because patients remember the experience for years afterwards because to them it's so amazing. They've had these symptoms for ages and they thought they just got them, and then they come to one appointment and they're cured at the appointment. So you get phoned up by people you think you've never heard of, and they say, I saw you in 1998 and you did, can I come back now? And you think, I can't remember that. I'm sure. You also have the problem of they send all their friends with dizziness. And most of them don't have benign positional vertigo, but they all think that maybe you could do the same for them. Don't become the local expert or you'll be overwhelmed with dizzy people.
Now, do you couple it with the habitual exercise or just this alone will do?
Pardon?
Do you couple it with the habitual exercise for vestibular rehabilitation or?
I don't think they're necessary in benign positional vertigo, but as I've said, in people with brainstem, small vessel brainstem disease or cervical osteoarthrosis, I would certainly think that the so-called vestibular rehabilitation exercises would be helpful. I think it's probably better to call them the vertigo rehabilitation exercises, because I'm not sure where the pathology actually lies in these patients.
Thank you.
May not be within the semicircular canals.
Yeah, thank you.
I am Dr. Subramaniam from Jipmar, Pondicherry. What is your take on these terms, miscellaneous head sensations and multiple sensory deficit dizziness? At one time they were quite popular, but
I have no view on them because I've never heard of them. Can you tell us a little more about them?
miscellaneous head sensations.
What are
It's a good term for the lazy physician. So when he tries and finds no reason, he says it's a miscellaneous head sensation. Or a multiple sensory deficit dizziness.
I'm going to write that down. Thank you.
Thank you very much. Thank you.
Ma'am,
Thank you,
I'm Ms.
Dr.
Hemlata. I'm a PhD scholar. I have a doubt that you said about dizziness and anxiety. Anxiety in elderly, whether this manicure will help those people. Because there are levels of anxiety, no? Whether it will be helpful for those people once you give this manicure.
I'm sorry. What's into?
Will your maneuver help people? Will your maneuver be helpful to people who have significant anxiety?
Will
the maneuver?
Oh no, I'm afraid not. It's very specifically just for people with benign paroxysmal vertigo. For people with anxiety, often showing them that it is just over-breathing that's causing their symptom and not anything more sinister can enormously reassure them. And teaching them exercises that if they feel their dizziness coming on, things like rebreathing techniques, that would be the best approach, not the maneuver.
Can I ask a quick question? What do you do about people with severe gait phobia? They're just afraid to walk. I mean, do you get older people like that, and what do you do with
Yeah, absolutely. The cautious of walking on ice skate. Physiotherapy again. Physiotherapists are my best friend.
Mine too.
So if there are no more questions, I think we could conclude this session. You will all agree with me that was wonderful. We thank the speaker. Give her a big hand, please. I also reiterate that I thank Professor ESK, Professor KS for permitting me or giving me the opportunity of chairing this session along with Professor Muttarasu. Thank you very much.
Thank you, Chairman, Dr. Kamachi and Dr. Muttarasu, and thank you, Dr. Nicholas College. And now we request the Chairman to give the memento to Dr. Nicholas College. And now we request Dr. ESK to give away the certificates to the chairperson. And now we are moving on to the third session of today and second part of the chronic disease management. That is the chairperson or Dr. Narsingan Yasan, who is Dean of the Professor M.E. Viswanathan Diabetes Research Center, and also he owns a nursing home on his own, and he is also the secretary of the API Chennai chapter. And Dr. Noorul Amin is a professor of medicine at Balaji Medical College, Chennai. I request both of them to take over the mic and do the proceedings. Thank you.
Good afternoon, everyone. At the outset, I would like to thank Professor A.S. Krishnamurthy for giving me this excellent opportunity to be here. to take part in this RCP scientific session. We have chronic disease management, which is going to probably cover two important topics on diabetes. The next one is on hypertension. For diabetes management in the elderly, we have an excellent speaker with us, Dr. Ramesh Chandrasekharan. May I now request Dr. Ramesh Chandrasekharan to come to the dais, please. Dr. Ramesh Chandrasekharan is currently the consultant physician and the diabetologist of Voluntary Health Service at AR, and he is also the chairman of the Type 1 Diabetes Research Unit of the same hospital. He is the vice chairman of the TAG Diabetes Research Center at VHS and runs a diabetes renal and dialysis service at the same hospital. He has had an extensive exposure in various topics of general medicine, both in India as well as in UK, and also a special interest in the field of endocrinology, nephrology, and tropical medicine. And he is a member of the Royal College of Physicians, United Kingdom. He is also the research interest in the field of type 1 diabetes, and renal diseases. Ladies and gentlemen, many of you know that the diabetes is now increasing in alarming proportions throughout the globe, and that too in our country. Our country stands as second next to China in the number of patients who suffer from diabetes. We know that we are also encountering a lot of problems of diabetes in elderly people. The way in which now there is an increase in the proportion of elderly, we need to pay more attention in people with the elderly with the problem of diabetes. If you take into consideration people above the age of 65 years, nearly 50% of them seem to have some sort of glucose intolerance, maybe in the form of impaired fasting glucose or impaired glucose tolerance, or they may be having a frank diabetes. 50% of them, among the 50%, you can have the frank diabetes. Such is the magnitude of the problem, even in elderly. When you face a situation of treating people with the elderly, you need to not only identify who are at risk in developing diabetes, who have already developed diabetes, what should be the management in that? What are the oral drugs that we can choose? Where is the role for insulin? Where is the role for combination of OAD as well as insulin? How best you can avoid the microvascular complications? How best one can attempt to prevent the macrovascular complications? And what should be the target level of HbA1c, which you always keep it under the level of 7 for normal people? What's going to happen for people who are elderly? Number of questions are there in our minds, which beg answers. Let us try to find out from Dr. Chandrasekharan.
Thank you, Dr. Narsingan. That's exactly why I will make my presentation pretty short, so that we'll have a lot of these questions about medications, the use of insulin, where to go, how much of an HbA1c you want to achieve, how do you balance all these problems. So thank you very much. I firstly thank Professor Krishnamurthy Srinivas, Dr. E.S. Krishnamurthy, all my colleagues here, members of the Indo-UK workshop, ladies and gentlemen. Now, the term, I'll go through a little bit of what is diabetes, what is the extent of the problem, before we go to the specific problem of diabetes in the elderly. The term diabetes mellitus refers to a group of metabolic disorders which is characterized by chronic or long-standing hyperglycemia. These disorders usually result from defects in insulin secretion or insulin action, or both. And sustained high sugars, or hyperglycemia, is associated with complications in the microvasculature or the small vessels and nerves, causing protracted morbidity and premature mortality. And macrovascular complications or large vessel disease, particularly coronary artery disease and stroke, are increased 2 to 4-fold, and diabetic patients have a higher prevalence of peripheral vascular disease. Microvascular complications such as retinopathy, nephropathy, that is problem with the kidneys, the retina, and peripheral and autonomic neuropathy are also common. So how does diabetes present? Unfortunately, most patients with type 2 diabetes are diagnosed in the relatively late stages of long and complex pathological process. They often have had pathological degrees of hyperglycemia for several years before the diagnosis is made. I apologize for the quality of the slide next. Well, most patients, like we said, are asymptomatic. That is, do not have any symptoms when we find them to have diabetes. What are the osmotic symptoms? That is, they sometimes do present with thirst, polyuria, nocturia, urination at night, blurred vision, fatigue, and lassitude. And the first time they present to you, they might have some infections, like recurrent fungal infections, genital candidiasis, recurrent bacterial infection like the urinary tract infections we often see, and the macrovascular complications. The first time they present to you, they might come with a coronary artery disease like chest pain, angina pectoris, acute myocardial infarction, and they can come with a stroke or a transient ischemic episode. And they could also present to you with problems with intermittent claudication or pain, pain in the legs when walking that is attributed to decreased blood supply or narrowing of the arteries supplying the leg muscles. They could also have retinopathy. At the time of diagnosis, they could have gone for a routine screening for problems with their visual acuity, and they could have find that they have diabetes for the first time. And nephropathy, like protein in the urine, they could have high blood pressure where you could find that there is some amount of damage to the kidneys already present. And neuropathy, like tingling, numbness, pain in the legs, cramps. There can be various types of nerve problems they could present with, and there can be a lot of associated conditions when you first find them to be diabetic. So classification is important because we are talking about diabetes in the elderly, where generally most of the people have type 2 diabetes, most of the presentation, most of the problems, the magnitude of the problem, maximal, is type 2 diabetes. But still, it's worthwhile to know what other types of diabetes are there, because any type of diabetic over age could get problems associated with diabetic complications. Type 1 diabetes is basically the islet cell. It's a beta cell which produces insulin. There's a destruction of it, usually leading to absolute insulin deficiency, and these people require insulin all their lives. It can be immune mediated or it can be idiopathic. And type 2 diabetes is quite heterogeneous in the sense that it ranges from predominantly insulin resistance and later on leading to insulin deficiency, and the main problem being insulin resistance to start with. There are other specific forms where there are a lot of genetics which come into play. Genetic defects in insulin action, genetic defects in beta cell function, diseases of the exocrine pancreas, and secondary endocrine problems which in turn lead to diabetes. And there are so many other drugs which are chemical induced, like glucocorticoids, etc. Congenital rubella is known to cause problem associated with diabetes, and there are so many other uncommon forms. And there is a specific type of diabetes called gestational diabetes, when diabetes is first detected during pregnancy. Why is it so relevant? We're talking about diabetes in the elderly, and as you know, diabetes begets diabetes. So a woman with a pregnant woman who has diabetes can transmit the problem to the child, and so this leads to future problems, and over the years to come, and we're going to face, as the population is huge, we're going to have problems with diabetes in the coming generations. So what is the actual burden of this problem? Like Dr. Narsingan said, this is a huge problem facing the world at large, and diabetes in India. So it's by far the most common form of diabetes is type 2, as we decided, and it's accounting for about 95% of all cases. During the past few decades, type 2 diabetes has reached epidemic proportions in many parts of the world. The increase is closely associated with the development of obesity. And the World Health Organization has predicted that the global prevalence of type 2 diabetes will be more than double. So that is from 135 million in 95 to about 300 in 2025. And that increase is seen not only in industrialized countries, but also a country which is developing like ours. So India is considered to be being in a stage of demographic transition, shows an increase in non-communicable disease proportions, including diabetes. The diabetic trend is towards increase not only in urban population, but sadly in the rural population too. And there is a lot of people who are migrating to the cities for job opportunities, for various other reasons. So you could see that the lifestyle changes do attribute to the development of diabetes, and it's going to be a huge problem. And what about the elderly? Globally, diabetes mellitus affects about 10 to 20% of the elderly in the age group 65-74 years, and about 40% of the elderly over the age of 80 years. So that's a huge number. Owing to better medical facilities, and this is important because a lot of us who have diabetes today, because of the increasing or better health care, are going to get much older and live longer. By the year 2025, it is expected that the majority of the elderly people worldwide will be residing in developing countries. Sadly, India is amidst a demographic transition with a trend towards an aging population. So, by 2025, 150 million elderly people will be found. So diabetes in elderly poses a special problem because there is a high degree of comorbidity. We talked about why we worried about diabetes. We'll see in the stages to come. The age-related impairment of functional ability, and there is an increased chance of hypoglycemia, which seems to be a major problem in trying to achieve normalized blood sugars. So just a small survey. We know global statistics about diabetes in the elderly. There's a small study which is done in Government Medical College and Hospital sector in Chandigarh. They found an elderly population in a catchment area, about 273 elderly registered in the geriatric outpatient departments. India, out of the 273 patients, the overall prevalence of diabetes was found to be about 27%. So 27 out of 100 people, of the 100 elderly, as compared to 12.1% elsewhere in India. And all the patients had type 2 diabetes. And the majority of the diabetic patients, 50%, were in the age group of 61 to 70. And 43 of the registered diabetics were males and females. That was almost equal. And which is the obesity was present in this population about 22 or 29.7%, which is comparable to the Framingham study, but higher than the study elsewhere. So the positive family, what else did they found? Positive family history of diabetes was found in 17 or 27% of them, and sedentary lifestyle was almost there in 50% of the population. So in 1985, about 27 million people, what is happening elsewhere? 27 million people living in the United States were over the age of 65. And half the people who have ever lived to the age of 65 are alive today. And currently, the elderly population of the United States is larger than the entire population of Canada. So these statistics are dramatic, and they are particularly important to a discussion of diabetes management, for the majority of diabetics are over the age of 55. And 10% of the population over 60, and about 16 to 20 over the age of 80 have diabetes, so 1 in 5. This is twice the prevalence in the younger population. And currently, the number of diabetics is doubling every 15 years, mostly because of increased longevity. So, what is the reason people have diabetes? Why do they get it? There are a few hypotheses, genetic and environmental factors, what we call the thrifty genotype hypothesis. So in 1962, Neil proposed that certain populations, including us, like South Asians, have a high prevalence of genetic traits, which once conferred survival advantages during protracted periods of meager nutrient supply, but which may now, due to today's living conditions and environment, may be detrimental due to abundant food supply and reduced habitual levels of physical activity. During the early 20th century, for example, the rates of obesity and type 2 diabetes among the P-Indians, which is supposed to be a very high-risk group, were both very low, corresponding with a physically active lifestyle and limited food availability, but all this now has changed. And there's the fetal origin hypothesis. Barker, it's called the Barker and Hale, Southampton and Cambridge, UK, provides an alternate to the thrifty genotype hypothesis of type 2 diabetes. It proposes that type 2 diabetes results, at least in part, from relative intrauterine malnutrition, and that later leads to lifelong metabolic programming. So you're already programmed. If you have a low birth weight, you're already programmed to have a certain amount of beta cell programming, which in later life, due to environment conditions, you put on weight, you get insulin resistance, and all the problems associated with diabetes. And this includes a reduced complement of islet beta cells combined with insulin resistance in skeletal muscle. And studies in population in which birth weight has been carefully recorded have consistently demonstrated a correlation between low birth weight and an increased risk of type 2 diabetes in the middle age. And this risk appears to be particularly high if obesity develops in adulthood. So other cardiovascular risk factors, including hypertension, also have been linked to low birth weight. And apologize for the quality of the slide. We just talked about the populations who are high risk, ethnic variation in type 2 diabetes prevalence in individuals aged 30 to 64. You could see that Pima Indians, about 50% prevalence. You could also see South Asians. I'm sorry. Yeah, South Asians down there who also fall into the high risk category. And what are the general comparison? What is happening nowadays as compared to what it was a few decades ago, or how our forefathers had lived? Is a comparison of traditional and modern lifestyles of Aboriginal peoples. We talked about the thrifty genotype, where this lifestyle, we used to be traditionally hunter-gatherer. Right now we are westernized, and the food supply then was erratic. Now it's pretty stable, and the energy consumption then was relatively low as compared to now, which is quite high. And physical activity levels are much lower now, and obesity is much more common now. And sorry about the quality of this slide also. The risk factors for diabetes, I'll just run through them. Overweight, obesity, family history. If you have a family history, there is a significant risk of the children, about 50% if both the parents are diabetic, to have a chance of getting diabetes. And age, and we went through the age. As the age increases, the prevalence of diabetes seems to increase. Hypertension, hypertriglyceridemia, and there's a peculiar condition where a lot of people now walk in the streets with a condition called pre-diabetes, where you don't have the symptoms of diabetes, but still you are at high risk of developing diabetes. Gestational diabetes we talked about earlier, and polycystic ovarian syndrome. And this is the diagnostic criteria. And today's to our arsenal of diagnosing diabetes, we used to have what we call as the oral glucose tolerance test. But right now, HbA1c, which is an estimate of 3 months average blood sugars, is also a good diagnostic criteria, and to screen populations with